And again, I told you I got the thankless job because again, every one of our speakers I could listen to for hours. Our next speaker is a very old friend of mine, Heather Hampel. She is a professor. She's associate director of the Cancer Genetics program at Ohio State University and a professor of medical genetics also at Ohio State University. And as I've mentioned to other people, if you ask clinical genetics experts who are the 5 leading authorities in Lynch syndrome in the United States, almost invariably Heather will be one of those 5 on that list. And so it's really a great pleasure that I introduce her. I'm looking forward to hearing her talk.
Thank you so much. I'm very excited to be here. And those of you who were here last year will know I did not have slides last year. We had a little snafu. So I'm even more excited that my slides are here. Also, you have seen the results of my study 3 times already this morning, which will make the first half of my talk go a lot faster. So we will just launch right in because of our 10 minutes. You've seen our disclosures. This is the 50 hospitals in the state of Ohio that we conducted the Ohio Colon Cancer Prevention Initiative in. The point I want to make here is that we enrolled 3,319 colorectal cancer patients from throughout the state. They were population-based, unselected for age of diagnosis or family history. That's why you're going to hear slightly different numbers from Elena and Matt and myself today about a prevalence of hereditary cancer syndromes. And don't think, well, one of them must be wrong. It turns out we're all right. It's just that we're looking at different populations. So I'm going to speak to you specifically about unselected patients diagnosed under age 50. These people did not show up in a high-risk cancer genetics clinic. They simply got colon cancer under age 50. Okay, so the study we published that you saw the data from earlier was the fact that all of these patients diagnosed under 50 got full genetic testing with a germline gene panel, regardless of whether they had MSI or not. And, sorry, there's the animation. The results are that 16% of all colon cancer patients diagnosed under age 50, unselected colon cancer patients diagnosed under age 50, have a mutation in a cancer susceptibility gene. 8% of them have Lynch syndrome, so fully half have Lynch syndrome, and another 8% have a mutation in a different cancer susceptibility gene. So I think it was Tabitha this morning who mentioned she had a BRCA1 mutation. We also found 6 BRCA1 and 2 mutations in our cohort. You'll see that from Elena and Matt as well. We certainly were not able to say that caused their colon cancer in any way, but it does seem to be more than we would expect to see by chance alone. So that's a signal many of us keep seeing. I will point out that not all of these genes have increased colon cancer screening guidelines. All of the Lynch syndrome genes do. The I1307K APC mutation that's common in Ashkenazi Jewish individuals do. MUT-YH carriers do not, unless they have a first-degree relative with colon cancer, and neither would any of the breast cancer genes that you see listed here. And that's going to become important later. If you look at the group that had defective mismatch repair, almost all of them test positive, and they all have Lynch syndrome for the most part. So here you'll see 77% of the patients with defective mismatch repair diagnosed under age 50 have Lynch syndrome. So if a patient comes to you under 50 that's MSI high, they're probably going to have Lynch syndrome. Here's the mutation spectrum. We did have 2 patients who had other conditions. One had constitutional MLH1 methylation and an APCI 1307K mutation, which probably had nothing to do with their colon cancer. The other has a PMS2 variant of uncertain significance that we suspect is pathogenic. There were 9 cases with double somatic mismatch repair mutations. Of those, 2 actually had biallelic MUT-YH or MUT-YH associated polyposis, which leads to acquired mutations, and in this case, they acquired mutations in the mismatch repair genes. The proficient mismatch repair arm, so these are people who had colon cancer under age 50 who were microsatellite stable. 8% test positive, and this is almost all the other half of the circle, the non-Lynch syndrome diagnoses. So 9 were in genes strongly associated with colon cancer, 13 were in genes not traditionally associated with colon cancer, 10 were in low penetrance genes. Just in case some of you have a problem with including low penetrance genes, if we take those away, 13% of unselected early onset patients with colon cancer will test positive for a cancer susceptibility gene. Okay, so this is where, oh, that got yucky. The table you saw earlier came from that said 16% of early onset are hereditary. We did know out of the 450, an additional 14% had a first degree relative with colon cancer, and I'm working with Fight CRC and Christine Momente to figure out what percent have a first degree relative with an advanced adenoma. But the question Dennis Ahnen astutely raised last year was, would these actually have been prevented if they knew about this before their diagnosis? And so we have a genetic counseling training program at Ohio State, and we've worked for the last year with one of those students to look at this data a little closer. So by the end of the study, we actually had 718 patients who were diagnosed under age 50 who had complete sequencing with a next-gen panel that are included in this particular series. So the numbers are slightly different from our published 450. We found 148 individuals who would be considered high risk in that they either had a pathogenic variant in a gene that does have colon cancer surveillance guidelines in the NCCN, or they had a first degree relative with colon cancer. And you'll see there's overlap, as you would expect. 33 people who have a pathogenic mutation in a gene that leads to colon cancer also had a first degree relative with colon cancer. So for the purposes of the study, we kept the 33 over here because the screening guidelines for hereditary cancer syndromes are always earlier and more stringent than the screening guidelines for someone who has a first degree relative with colon cancer. So this left us with 83 people with a pathogenic variant in a colon cancer gene and 65 who had a first degree relative with colon cancer. So we actually looked at what age they would have been recommended to start their colonoscopies, and at what age they were diagnosed with their colon cancer, and if they would have started their colonoscopies more than 5 years prior to their diagnosis of colon cancer, we considered that diagnosis potentially preventable. If they would have started their colonoscopies between 1 to 5 years prior to their diagnosis of colon cancer, we considered it potentially downstageable, but not preventable. And we can argue about that cutoff later. So of the hereditary group, the bottom line is that our hereditary guidelines in NCCN work really well. 82 of them, which is 99%, would have initiated surveillance prior to their diagnosis. This means if you knew you had Lynch syndrome when you were 20 years old, we could keep you from getting colon cancer. 79 of those were more than 5 years prior to their diagnosis. 3 would have been potentially downstaged because they were within 5 years of their diagnosis. The only one would have neither been prevented nor downstaged, but an MSH2 pathogenic variant who was diagnosed the same year they would have been recommended to start their colonoscopies at 20. This is an unusual use of a waterfall plot, but what you can see here is how many years they would have started their colonoscopy prior to their diagnosis, which is at the 0 line, and anybody who would have started more than 5 years before their diagnosis would have prevented their colon cancer, and essentially everybody. The family history group. So in family history, as you guys know, the recommendation is to start colonoscopy 10 years before the earliest diagnosis in your family, or at age 40, which is ever is earlier. So we went through by hand on each one and named the age they should have started their colonoscopy. This did not work as well as the hereditary cancer guidelines. So 53 of the 65, or 81%, would have initiated surveillance prior to their diagnosis. That includes 37 who would have potentially prevented it, and that they would have started more than 5 years before their diagnosis. 16 that would have been potentially downstaged, and 12 that would have neither been prevented nor downstaged by starting at age 40. Dennis is always talking about we don't really have any data for this 40 number. I think this starts to get at it, and I'll talk to you a little bit more in a minute. So here you can see it doesn't work quite as well, the family history guidelines. These people would have all been diagnosed more than 5 years before their diagnosis. These were within 5 years and maybe downstaged, and these were all diagnosed with cancer before they would have been recommended to start their colonoscopy. So what if we changed it to 35 at the maximum, 10 years before the earliest diagnosis in your family, or 35, whichever is earlier? This is kind of logical. It's something we've been discussing at NCCRT since the general population moved down 5 years to 45. Should people with a family history also move down 5 years to 35? And you can see, naturally, it works better. 51 of them would have been caught more than 5 years before their diagnosis, or 78%, compared to 37, the 57% with the current guidelines. It also results in an additional 6 being screened within 5 years of their diagnosis or potentially downstaged. So here you can see the overall table with the hereditary cancer syndromes here, first-degree relative with colon cancer here, how many would have had a colonoscopy prior to their diagnosis if they followed guidelines, how many would have had their cancer prevented, in other words, started more than 5 years before, how many would have had their cancer downstage, how many would have had neither occur in the total. And we did take a moment and look at the patients who did not have a first-degree relative with colon cancer or hereditary cancer syndrome. We looked at what if they had started following the new ACS guidelines and had their colonoscopy at 45. None of them obviously would have been prevented by our rule of starting more than 5 years before, because everyone in the study was diagnosed under age 50. However, 41% would have had their diagnosis potentially downstaged. Sorry. And I'm getting my beeper that I'm out of time, so I will just give you the overall results here, and that is 16.2% of early onset colon cancers identified in our unselected Ohio study would have been able to potentially prevent their colon cancer if they had known about their family history of a first-degree relative of colon cancer or their mutation that gave them an increased risk for colon cancer as an adult and been told the proper screening guidelines and followed them. They're completely preventable. 19 could have had their colon cancer potentially downstaged, and that they would have started within 5 years of their diagnosis. And in conclusion, 16% of early onset colon cancer cases are hereditary or due to a mutation in a cancer syndrome. 16% are potentially preventable. And surveillance guidelines for hereditary cancers are more effective than those for a first-degree relative with colon cancer. And the age to start for a first-degree relative may benefit from a downward adjustment. Thank you.